Well, hello everyone. This is your friendly rheumatologist, Dr. Amig, and this is another episode of Rheumatology 101. Today, I want to discuss with you interstitial lung disease, specifically in rheumatoid arthritis. So it's called RA-ILD for interstitial lung disease. The first thing is let's review what this is. And the second thing will be how we diagnose this. And finally, we will talk about what you can do and what we can do. As always, I'm a very optimistic person, and you're going to see this is optimistic just as well, okay? So number one, what is rheumatoid arthritis associated interstitial lung disease? And to go over this is what is interstitial lung disease? So when you're taking your lung, I'm just doing this because it's usually, we have two lungs and they are, around the chest like this, around. And so we have two of them. And there's can be many issues associated with the lungs. Either is the airway. So when you're breathing, it goes from your mouth, down your trachea to the main bronchial, and then the smaller bronchioles and all the way to the bronchioles, right? So it goes smaller, smaller, smaller. You can also have the pleura, so that's the lining that's around the lung that can get inflamed. So the pleura can cause problem. Maybe there is some water or some blood, and that can compress the lung. That's a problem too. You can have issues in the vessel because you need, right? So we are taking the air in, the air as the oxygen. The oxygen goes all the way to the alveolar where there is the barrier with the vessel, and then the vessel takes that oxygen and give back the CO2, the carbon dioxide. Sorry, I had it in French, CO2, and then you're bringing the O2, right? And then the blood is going to then distribute it everywhere, including the heart that's going to pump it and then go all over your body. Okay, so that's great. We're so well done, right? And this is really just an overview, just so that you understand. Well, when you have interstitial lung disease, we cannot, we basically are talking about the interstitium, so the tissue that's in between the alveolar. And so what that means really is that you're going to have an issue of this barrier between the exchange of the oxygen between the airway and the vessel. And basically, you're going to have an issue, and that's going to cause to have less oxygen and less oxygen exchange. So that, just understanding that's kind of cool. You're like, okay, well, there's different issues in the lung, and that's, one of the issues. Truly, rheumatoid arthritis can cause every single pulmonary disease you can imagine of. It can cause the pleura to be inflamed. It can cause some bronchitis, so inflammation of the bronchiole, so that's the airway. It can cause rheumatoid nodules, so nodules that can be excavated, open. So then you can, cough up blood. Those things, honestly, we used to see them a lot, a long, long time ago, but now we have amazing treatments. So there's no reason to see that. But it can still cause interstitial lung disease. And we see that usually it's at the same time that something called idiopathic pulmonary fibrosis happens. So we actually think that there's probably some sort of related mechanism of why they happen. But that, would be around 60, 65 years old. And so it's important because I keep saying rheumatoid arthritis, we can get you to remission with our treatments. They do really well. And you can, just be super optimistic and just aim for perfection, because I really mean it. But another reason is that, we don't want you to develop rheumatoid arthritis associated interstitial lung disease. The lung disease, the interstitial lung disease in rheumatoid arthritis, we think starts with inflammation that we don't necessarily pick up, and then it gets to the scarring. So fibrosis is just a very fancy, I think it's Latin or Greek, I can't remember, word for scarring. And basically what it is that instead of having this very nice functional tissue, you just have a scar tissue, and that does not do what it needs to do when it comes to exchange of the O2 and CO2. And so then you're going to have these issues. And once you have scarring, you cannot go back. And that's the issue. You can prevent it from getting worse. And so we have treatment to do that, but you cannot go back from scarring to normal tissue. The day we do that will be very exciting, and I'm absolutely certain we will at one point be able to do that, but we're not yet there. And it's going to take quite a bit of medical science to do this. And I'm talking scarring in general for everything, because that's a problem in your heart. What is a heart attack? It's when you have scarring. Like, the issue is if you develop scarring of your tissue, and that can cause heart failure. Same thing with the lungs, same thing with the skin. If you have so much scarring, then, you know, the skin is not as elastic as you want it to be. So all of those things, just really to understand the issue. And so the interstitial lung disease in rheumatoid arthritis starts approximately at the same time than the patients that have idiopathic pulmonary fibrosis. It has a little bit of a better outcome. So please don't look at internet, because it's going to stress you out. This is outdated. Talk to your pulmonary doctor, and talk to a pulmonary doctor that is specialized in this. That's really important, okay? And when you're going to look at the chest X-ray, you're going to see that there is at the base haziness. And then you're going to do a CT scan, because chest X-ray are not as good. You do a CT scan, and then you're going to see honeycombing. And it's really like, I want you to remember that word honeycombing, because you could actually, like, if there is honeycombing, that's really when there is scarring. When your rheumatologist is going to look at you, they're going to ask you, do you have any shortness of breath? And then they're going to also take the stethoscope and listen, and we hear crackles. So that does this at the base of your lungs. It's actually not as wet as what I just did, but really just imagine a Velcro, and when you rip the Velcro, it does. I'm not good at sound, but you know what I mean, like a Velcro, and we can hear this at the base of your lungs. So the way it presents is usually you may have a little bit of cough, but really what's going to happen is that when you're walking, when you're running, you're going to start having some issues with breathing. You're like, I'm feeling short of breath. So if you have rheumatoid arthritis and you're feeling short of breath, please, 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 pretty please, tell your rheumatologist, because the truth is that we rheumatologists need to listen to your lungs. But unfortunately, I know many, because of the constraint of time, which is another reason I, ditched the insurance, but the constraint of time makes it that they don't necessarily have the time to listen. If you have any sort of shortness of breath, ask your rheumatologist to listen to the base of your lungs. Like, even if it's just 2 things that they listen, that's all you want them to do, okay? And in fact, I would recommend that you ask your rheumatologist to listen to your lungs every single time you go there. Because you should, they really, that's important. I picked up another case recently, just because no one has ever listened to him, and that is a problem, because we have treatment, and the earlier you treat, the better. And so let's talk about how. Yeah, so I said how we diagnose it. So we are looking clinically. We ask you, like, shortness of breath, mostly. Do you have any sort of shortness of breath or desaturation when you're walking? That's really important. Or like doing some exercise that normally you would not have issues with. Second is the chest X-ray. Not the best test, but really it's going to tell us a little bit maybe. And then we do the high resolution CT scan. That really tells us what's happening. And then we can also do pulmonary function test, in which we're going to really look at this barrier. Like, we can actually test the barrier exchange between the lungs and the blood, and the vessel, and how you're doing there. So once we have a diagnosis of interstitial lung disease, so the good news is that the vast majority of time we don't need a lung biopsy. We can make the diagnosis based on the way it's presenting on CT scan. So that's, that's something to be hopeful and to be grateful for, since, the science, we used to do biopsy, and now we don't need to do biopsy. So that's great. And then we're gonna, once we have this diagnosis of RA-related interstitial lung disease or pulmonary fibrosis, is really, then we need to think of treatment. So in terms of treatment, the really good news is that we think that getting our patients to complete remission in rheumatoid arthritis actually probably prevents some of those lung disease. So we're not going to know just yet because, right, so if you've developed at 40 years old your rheumatoid arthritis, and if it starts at 65, we need 20, 25 years to know if our new treatments, those biologics and all of those things, and the fact that we're now treating to target to get patients to remission, does that have an impact? And I'm absolutely certain personally, but does that have an impact on the lungs as well? Or it doesn't, and it's going to take some time to get there because the biologic started, 20 years ago, and that was the first, and really we were using biologic a lot only for the past 10 to 15 years. So it's going to take a time to really look at that, and we're going to look at it, right? But then treatment. So prevention to me, I think, is getting your rheumatoid arthritis to full remission. That's number one. Now, second thing is treatment. So when we make that diagnosis of rheumatoid arthritis ILD or RA-UIP or RA-ILD, and if someone has told you that you have idiopathic pulmonary fibrosis and you have a diagnosis of RA, please reconsider. You probably have RA-ILD and not IPF. And that's actually quite important because the outcomes are way better for RA-ILD. And so if you were to have RA-ILD, we have treatment for your RA. And there are some treatments that we prefer to others that are going to treat both your rheumatoid arthritis and we think probably also help your lungs. So we have biologic that do that. So certain biologic we think can lead to worsening lung disease. It's not completely proven. For example, TNF inhibitor, we don't really like. And then some other ones where we think that it actually helps. So for example, Rituxan, there are some case report and case reviews, and there is actually probably going to be a randomized control trial for this. And I was a little bit of a help for this in the US. I'm very excited. And we're going to look at this, okay, and Rituxan. But there's really not a lot of study. We just think that, treating your RA is probably helpful. And there are some treatments that prevent the progression of the scarring, the fibrosis. So that also helps. Finally, and this is something that you can do, finally, preventing worsening of the lungs. And so that is the reflux. So if we can prevent reflux of acidity in your mouth, basically we don't want any of the gastric acid to come into your pulmonary tract. To do this, honestly, sometimes the only thing that you need to do is to just elevate the head of your bed and do this when you're sleeping. Make sure that you're not flat, but elevated. Your head is elevated so that even if there's reflux, and all of us had a little bit of reflux, even if there's a little bit of reflux that goes up, it comes down before it reaches the bronchial, the main bronchial. So that's pretty much what I wanted to share. Preventing infection is also an important one. You don't want to have pulmonary infection so that you can prevent, further damage to your lungs. That was really the overview. I will tell you, I work super closely with interstitial lung disease docs because I absolutely adore them. And they work at National Jewish. So if you were to be one of my patients, I would probably work with National Jewish doctor. This is, if you have an interstitial lung disease, highly recommend that team. They are phenomenal. And I work with them because that's important to work with someone that specializes in interstitial lung disease. So you're at the forefront of, the new science. So that's my recommendation, is basically make sure that you take care of your rheumatoid arthritis as soon and as well as possible to prevent any sort of GERD and reflux, and make sure that you're seen by a proper specialist in interstitial lung disease. All right, I will see you next time. I hope this was useful. You can subscribe, you can comment, and then you can also check my other channel, which is called Unabridged MD, where I talk more just anything health related. And it's not just rheumatology, although, that's where I'm specialized. So that has this lens of rheumatology. I hope this was useful, and I will see you next time. Bye-bye. Thank you.